All right, Tracy, I just sent you the link.
Yep, just came through. Okay, let me check, make sure it's working. Okay, y'all are good to go.
Thank you.
You're welcome.
Okay, Ms. Crystal.
All right, I think we can go ahead and call the meeting to order. And I think I need to say that any comments can be emailed to public comment at lsbme.la.gov. And I think the first thing we need to do is introduce everyone on the call. So Dr. Collada, do you want to start?
Yeah, I'm Vincent Collada. I'm the Executive Director of the State Board of Medical Examiners and serve ex officio on your committee to help you get things done. Thank you very much for attending tonight.
I'm Crystal Chase Cercello. I guess I am chairing the committee, and I work as a family medicine PA at a rural family practice. Miss Susie?
Yes, I am Susie Allen. I am research and education for the board, and I will be speaking very, very briefly just to update you about where we're going in terms of the PA rules course. Thank you.
Miss Payton?
Hi, my name is Mary Payton. I'm general counsel at the board, and there's an item on the agenda with regard to follow-up on requests for an advisory opinion, and I will be addressing that. Thank you.
Barsha?
Hi, my name is Barsha Castro-Gussman. I am a physician assistant advisory committee member. I also serve as the PA program director for Xavier University of Louisiana PA's program, as well as a practicing PA in neurocritical care at Ochsner.
Miss Patricia?
Hi, I'm Patricia Wilton. I'm executive counsel for the board and sitting in to assist as needed.
Sabrina?
Good evening. My name is Sabrina Weathersby. I'm the Director of Large of Louisiana Academy of PAs. I'm also a practicing PA at the New Orleans VA in New Orleans.
Sarah?
Hi, this is Sarah Deo. I am the legislative chairwoman of the Louisiana Academy of PAs and program director of Franciscan Missionaries of Our Lady University's PA program in Baton Rouge.
Dr. Craven?
Yeah, my name is Jimmy Craven. I'm been nominated on the board, serve as president of Our Lady of the Lake Physician Group, as well as president of our health systems physician group across Louisiana, Mississippi.
Olivia?
I think Olivia's just listening in. So she's the executive program specialist for the LSBME.
Raven?
Good evening, everyone. My name is Raven Lewis. I'm a physician advisory committee member and a practicing physician assistant in pediatric orthopedics at Ochsner.
And then I think Tracy is the only other person, and Jacinta.
Tracy Moore, IT support for the board.
Okay, I think we can go ahead and move on to the agenda. The first item of business is to approve the meeting minutes from October. I know you all should have received an email that had that typed up. Do we have a motion to approve it or questions about it before a motion? Do we have a motion to approve it?
Yeah, motion to approve.
Is there a second?
Second.
If anybody doesn't know, no opposition, I think we can move on. And then I believe Dr. Colada wanted to do the request for advisory opinion about treatment of chronic pain prior to the rules course discussion. So I'm going to turn that part over to you all.
Hi, everybody. This is Mary Payton. So if we could turn to page 6 on the agenda. A couple of, I would say maybe a month or two ago, when you previously met, I guess it was October, we presented a question to the board from a practicing PA that would like, the board would like the committee's consideration and recommendation regarding some of the questions that the PA practitioner had. And question number 1 was whether the treatment of chronic pain with non-opioid and neuropathic medication, non-controlled agents, and joint injections may be performed by a Louisiana physician assistant. He wrote including prescription of NSAIDs for chronic pain or what he considered pain over 12 weeks, and or performing joint injections for pain over 12 weeks. He added, when I went back to him with some questions that you gave me in October, he added, can PAs utilize NSAIDs, APAP, Neurontin, or other non-scheduled medications for chronic pain, any pain that has lasted longer than 12 weeks, conditions such as OA, which I assume is osteoarthritis, and diabetic neuropathy, RA. You guys had some questions, and that's at the bottom half of the sheet. You asked for his practice guidelines, training and education applicable to injections, and you can see his answers across from that. And I'll just let y'all take a look at that for a minute. And I think last time we met, Dr. Cresswell was on and expressed some concern about Rule 4506C, and that can be found on page 9. So C states a physician assistant who has been delegated prescriptive authority shall not, and then dropping down to number 3, treat and or utilize controlled substances in connection with the treatment of, dropping down to A, non-cancer related chronic or intractable pain as set forth in 6915 through 6923 of the board's rules. And so from my perspective, reading that, C clearly is limiting this section to those who have been delegated prescriptive authority, and is saying that they cannot treat or utilize controlled substances in connection with chronic pain. Going back to our practitioners' questions, it looks like he's trying to use non-controlled substances, but he's concerned about treatment of chronic pain and would like the committee's thoughts on that, and a recommendation to the board with regard to his questions as stated in the upper half of the page.
This is Crystal. I absolutely agree that prescription of NSAIDs for chronic pain, you're treating arthritis. Someone's going to have arthritis for over 12 weeks, but the whole goal, like I said back in October, is to keep people off of opioid pain medicine. And the rule to me appears that it is treatment of chronic pain with a controlled substance. That's what's not allowed. And NSAIDs, joint injections, those are well within a PA's, what we're taught in training. So I don't see that there is a problem with it. If anybody else has any opinions, I'd enjoy hearing those.
Does everyone agree?
I would support that. I mean,
I'm in agreement as well.
I as well.
So your recommendation to the board would be that PAs are in fact allowed to prescribe NSAIDs for chronic pain and allowed to perform joint injections for pain over 12 weeks. Is that correct?
Yes.
Great. All right. Does somebody want to make a motion as to adopting that as your recommendation to the board?
I make the motion, however you word it, to get us through this. I would support that.
Be word, just like I did before, answering that, yes, physician's assistants are able to, within the rules, prescribe NSAIDs for chronic pain and perform joint injections for pain over 12 weeks.
Could I move to divide that question? I think the board would be happier if you took both of those separately, because I'd like to find the authority for the joint injections as he described, because there's some issues about, joint injections being surgical procedures and that kind of stuff. So maybe we should divide it and clear about the rules. We clarified the one about the NSAIDs, and I'm comfortable with that, but let's look a little deeper on the other one, if you don't mind. Could we divide the question in two so that the board doesn't get try to get both of them together?
Look, I'm fine with dividing in two, but it's a tough swallow for me to say we're going to make a motion to allow somebody to prescribe Tylenol at this level. But if that's what we got to do, let's do it.
Well,
I mean,
again, then let me explain to you that he says he's injecting Depomedrol, lidocaine, and bupivacaine into the joints. That's something that he, by rule, cannot do, number one. Number two, at the present time, under the rules that we're going to be proposed to change, you all would be billing this. Right now, he can't bill it, so the office has to bill it, but they would be billing a surgical code when the rules change to allow you to do it. And you all, PAs, are not allowed to do surgery except to assist in surgery. And so we want to clarify that for what you think the board should do in this matter. It's not what I want to do, it's what you want to recommend to the board to do. So that's why I think it's important to clarify that for the board.
perfect. Break it up in two. Two motion. The first motion, approving Tylenol for the management of chronic pain greater than 12 weeks, or
No, it's NSAIDs, not Tylenol. NSAIDs.
NSAIDs, ibuprofen.
The whole generic class of them. That's what we want.
Yeah, that's great. Does anybody? I put the motion forward.
I second it.
Yeah.
So I'll second it.
Any opposed? I'm not running the meeting, but I'm trying to just go through the process so we can get to the meat of the matter here.
No. No opposition.
They've got NSAIDs. Next motion.
That would be motion to approve performance of joint injections for pain over 12 weeks. And if you want to take each one of those, I don't know if Depomedrol, lidocaine, and bupivacaine is the issue, or if there's also cortisone to be considered, because he also specifies cortisone and then says Depomedrol, but then also says the lidocaine and bupivacaine. So however you want to break that up.
Can we just make it generic and say joint injections?
Well, to address what's going in. I think that was part of what Dr. Collada was saying, is that the board would likely want to know y'all's opinion based on what you understand is being injected.
I mean,
as well as,
could we say analgesics?
Well, okay, just so you'll know, I'll highlight something here for you. And tell you that right here, administer local anesthetics they may not, perineurally, epidurally, intrathecally, intravenous, unless physician assistant is a certified registered nurse anesthetist and meets the requirement. So that's what I'm concerned about in the present rule and what we would probably have to change in the new rules if you want to do that, number one. And then the other thing is, if you're billing a surgical code, which you would be doing with this, is then you are claiming that you are doing surgery. And the rules at this point do not allow that to occur, except as an assistant to surgery. And I understand that the gentleman has taught residents, and I understand, but I just want the board to, the advisory committee to hear what the board thinks about his specific request in light of the current rules and what you might want to do in the rules in the future.
So the rule says administer local anesthetics, but it doesn't say intra-articular.
It's a physician assistant shall not
Right.
administer perineurial, epidural, intrathecally, or intravenously unless such physician assistant is a certified registered nurse anesthetist. Okay, so if he's he's talking about joints, but joint injections could be knees, they could be shoulders, they could be in the back joints. Okay, so I think we have to be very clear what we recommend to the board in the light of these rules. And then the other thing is, surgical procedure codes used for this would in fact make this appear to be surgery. And I want to make sure you all know how you want to change make a recommendation on the current rules and what you want to change in the future rules.
I do believe they asked in some of their questions to him in the October questions, the area of the body for injection. So if we could go back over to that.
Yes, ma'am.
On page 6. So it's the third question. That's what he's injecting, like the physical body part.
Can we say large joint injections? So
you
we're-
can recommend anything you want, Miss Crystal. You really can.
Yeah, if you want to say knees, AC, and subacromial joints, then you could say that, if that's what you want to limit your opinion to.
So this is just
Is it more of a concern having an injection in the back versus the remaining joints? Is that the concern or the question?
Well, there are two concerns that I want to clear up for the board, okay? And I want your opinions on. One
Mhm.
is, these are surgical procedures by definition, okay?
They are,
And-
but they're performed in offices all the time, and they're not, even though the billing code is surgery, we know it's not performed in the surgery center, nor is the person anesthetized to
Well,
receive an. We know that.
we have rules about office-based surgery, okay? And this would be part of office-based surgery, okay? And since it is surgery, we have to clarify what you want this to say. So rules right now, they say that you can only assist in surgery. Whether so if you're doing these procedures, there are exemptions in the office-based surgery if you use nothing but local. But if you begin to use anything else in addition to local, you could be coming under the office-based surgery rules. And I know this is kind of complicated, but that's why I want to clarify it. So when we tell the board, this is what you think should happen, this is what you think the rules should be in the future, we can make that clear to them. And that's where they don't have nobody says, well, you're violating the rules. You're going to make an exception to the rule. I just want to make sure you get what the message you want delivered to the board.
Right. I think what we're trying to recommend is that physician assistants should be allowed to perform in office large joint injections intra-articularly only, utilizing analgesics without any type of conscious sedation. If that's where you're going with like surgery and getting any deeper than outside of local anesthetics.
Okay, again, that's one issue, and I'm very comfortable with that, and we'll make that recommendation for you. The other issue is whether it's office-based surgery or not, it is surgery, okay? And according to the rules, you all are not allowed you're only allowed to assist in surgery. So while I'm comfortable with you recommending that they should be allowed, PA should be allowed to do this and the rules should be changed, I just want to know, I want to make sure you address those issues so the board can hear what the advisory committee wants.
I think that we need to, I mean, I understand the surgery component, but I do think that, you know, doing something like this, you're doing it within the scope of, PAs are doing this within the scope of their, what we're allowed to do, as well as what's indicated. I would, so Miss Mary, how do we phrase this? So we've done the NSAIDs, we've moved on. So you're
Right, so, I think it was Raven perhaps that articulated it earlier. Basically, it sounded like the recommendation would be that PAs are able to do in-office intra-articular only large joint injections with local anesthetic. And to address Dr. Collada's question about whether this means y'all want to change in the rules, separately, y'all could do a motion to recommend that to the degree there needs to be a change in the rules as to being able to do these in the office, even if they are perhaps categorized as surgery, that would be allowed. And that y'all would be asking the board to change the rules in that regard to allow for that.
I would like to make a motion for exactly what she said. Is that possible?
Yes, ma'am.
I second that.
Anybody second it?
I second the motion.
Who was that second? I apologize, I missed it.
Varsha Gusman.
Okay, thank you. Thank you, Ms. Grossman. So again, you need an all in favor and any opposed.
Can I get an all in favor? Say aye.
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 Aye. No opposed.
Thank you so much for clarifying that.
I think now we can move on to the next point, which is the rules discussion.
Actually, let's take Susie so she can be on her way. We thank Mary for her help tonight, and Susie, well, tell us about the rules course, and that way we can let Susie be on her way.
Okay.
Thank you so much.
Okay, I'm just tuning in with video so you can see me. So I know I've spoken to you all before. I just want to give you a brief update and sort of ask for, verify volunteers and so forth. So as you may recall, a couple of things. We have had a PA rules course for quite some time, and currently candidates for licensure take that rules course as part of the things they have to do in order, along with their application to get newly licensed with us. So several things. One is that course will be moved over to a different platform, or really two different platforms that are sister platforms temporarily. But the other thing is that there is a rules effort in place so that instead of taking this course as part of as a requirement for initial licensure, it will be required for PAs and all of our licensees to take a rules course upon, but right before they, as a condition of their first renewal, rather than as a condition of licensure. So I'm about to be in the process of taking our existing course and kind of making sure it's up to date, and maybe updating some of the quiz questions and so forth, looking at how people have done the quiz questions before to make sure that our quiz questions are as good as they can be. And so I just wanted to let you know that this is going to start happening in the new year. And after I have moved it over to the new platforms and so on, I will probably be asking, or really in that initial process, I might be asking, say, two of you to look at the quiz questions and give me feedback or suggestions for new ones. And, I do want to stress that what we like on these questions are scenario-based questions, where our candidates, or soon to be our recently, completed first year licensees can demonstrate that they understand the rules in a real life scenario, so that they are not either tempted to violate them or inadvertently violate them because they weren't aware. So that's, that's the function of the rules course. And as I said, it's going to change format slightly. It will also give people who take it some automatic CME or CE or CME, I guess, with PAs. So I wanted to sort of let you know that, and also ask if there are perhaps two of you who would be willing to look things over before the rest of the group sees the final product.
I will. I'll look it over.
Okay, Crystal, appreciate it. Okay. And certainly once this is up, the other thing that we've been doing as we move these courses over into the new format is we let the different licensees groups know, this is a requirement early on in your career, but we encourage people to take these courses at any point just to refresh their knowledge of the rules, since there are plenty of people who probably have not really looked at the rules in many, many years. And so if any of you are in that category and you decide to take it or what have you, and you have any feedback about the course or about something that you think, should be tweaked, you are more than welcome to tell me. Does anybody have any follow-up or questions about that?
Susie, this is Sarah Deo. I don't know if it's appropriate for me to speak. If I'm allowed, Crystal, am I allowed to interject?
You can make a public comment.
Okay.
Sure.
Well, I mean, I think as a program director, I think I would be happy to work with you to incorporate this into our summative assessments of our students. I think we all are required to teach this from an accreditation perspective. So, I mean, we could even incorporate it for grade to ensure that it's done. If you guys want to be the ones to present, just to make sure it's happening. Well, it's happening as a requirement for licensure, but to emphasize the importance of it at the end of the PA's education, and would be happy to incorporate that somehow into curriculum.
Okay. I know over the years that Joe Bonk, one of our compliance officers, periodically has in the past gone to different PA programs and sort of given a lecture about the rules. I don't know if that includes your program or not, but I know that at different times he has in fact spoken to different PA programs.
He has. I guess I was referring to the actual course and the test, the quiz that they have to take. We could easily incorporate.
Well, I think, there may be some ethical issues about that in terms of one group being more privileged with the information than others. So I'll have to ponder that one.
And the only thing I would tell you, Sarah, is what we've done, or what we are trying to do, I think, is expedite the time from application to licensing without having a delay to take the course. That way you'll just take it at the end, but before you renew for your first year. After you've been licensed, you renew after your first year, you'll have to take it then. Nobody has to take it before they get their license. What we're trying to do to expedite the process of licensing and get people to work as soon as possible.
Where can the course be accessed?
Well, at the moment, it's on a one system where you have to have an enrollment key to access it. What will happen is there will be a period where it will still be being utilized for initial licensure, and then once the rule passed that everybody has to take it for their first renewal, it will be on CE Broker, which is our electronic education tracker for all of our other groups. I realize that for PAs, your CME is calculated, through NACCPA or something else, but there is going to be a situation where PAs will have to create a CE Broker account to take that course so that it can be tracked. And anybody else who just wants to can take it, and it'll be free.
Thank you.
Any other questions from me?
I don't think so.
Okay, well, thank you very much, and you'll be hearing from me. Thank you.
Thank you, Susie.
I think next on the agenda, it says we've got the direct billing and reimbursements, and then some letters from outside organizations. I don't know if Dr. Clotter, you want to talk about the reimbursement, or if that's actually something that needs discussion.
Well, I think what we would appreciate, we've not talked about this in the proposed rule changes. It's something that I think is reasonable to say. It would go along with current federal guidelines, and I think it would be helpful if you say we should allow in the new proposed rules to allow you all to do direct billing. Now, I know that many of you all, and as we're structuring this, we probably need to recall that we're going to be structuring this for the large groups and the traditional dyads, so that the dyad may not want to do it, the large groups may not want to do it, but anybody has the right to do it. And I think that's the key. It's going to be optional, because in a larger group, you may not be actually doing the billing. Somebody else will do the billing for you. But then again, you would be responsible for the billing that the group does for you. So again, that was the thing that we wanted to address. And I think if everybody's comfortable with that, and you want to do anything different in the terms of billing, please tell us, because Pat and I are about to try and put together all of the suggestions you've made and make these rules something that you can look at in the next couple of weeks, and then present them to the board. Hopefully, if we get it done in early enough in January, we could present it at the January meeting, or else first thing on February.
So do we need a motion to say that we want a rule that allows to follow federal guidelines for direct billing?
I think that, yes, so that it's optional for people who want to direct bill. It's not necessarily mandatory, because some people in the traditional dyad may want to continue to just have the doctor that they work for bill. I think the issue is, do you want it to be mandatory that everybody does it, or do you want it to be optional that depending upon the scenario, how it works? Because I want everybody to understand, if when I worked for a large hospital group, I just gave them the code. They did the billing, and I was responsible for the proper coding, but they did the billing. And so I want everybody to understand how these things work in real practice.
Sarah, I know this was an LAPA thing. Can you chime in on that? So essentially, if we have a motion that says we want direct billing to be a rule, that's essentially all we need here tonight. Is that
Actually,
right, Dr. Potter? Or go ahead.
Well, I think that what could simplify it is as far as, and this is a question I raised in October, probably directed to the attorneys in the room, because I'm not sure. LAPA had done some initial legal research. We could not find anything statutorily that limited direct billing and reimbursement, but the rules do prohibit this. So what LAPA's proposal was, just strike it, and that would simplify and allow the flexibility that Dr. Kulata is referring to. And this is not, so I guess in the spirit of this is not so that the PAs are literally billers. It's just unlinking that requirement to the physician's NPI number, in increasing transparency in billing practices, and also allowing for the reassignment of benefits in institutions where that's required, and PAs are not able to do that because we're prohibited in the regulations from doing so. So I hope that simplifies, but we were just recommending just strike it and it altogether.
Well, if I may, Crystal, you seem to be one of the people that still works in a classic dyad.
Not really.
Okay.
I work for a federally qualified health clinic, so not really. So it's a group more than just a doctor physician or PA, doctor PA.
Let me ask you this. Is your salary and benefits based around your billing? Or
No.
is it okay.
Mm-mm.
So see, that's why I want to leave it as optional. But if you think we just strike it and it turns into a free-for-all, some people are going to say, well, I don't, if you're a flat salaried person, what difference does it make how much you bill? But if you're a production-based person, it's really important to do it. And I want to make sure we give some flexibility to all kinds of practices that PAs do.
I agree with you on that.
Okay. If everybody's comfortable with that, Pat and I can make that happen in the proposed rules that we submit to the board and hopefully to you all before we submit it to the board.
So again, this is Sarah. I would just really caution against from our perspective, two sets of rules, or where there's been maybe some ambiguity in rules, really causes headaches at the administrative logistical level for people to try to figure out which way to go with something. So LAPA's intention with the things that we had requested were really to simplify and eliminate confusion as much as possible. And so that's my only concern is whatever is drafted, if it's worded in such a way that people can't understand them. And another good example of this is a performance plan, is that they just default to doing sort of more than what's necessary because for fear of breaking the rule, essentially. So
well, let me say this to you. For example, Crystal, I think you take large groups, okay? Whether it's the group where Crystal works or people that work at Oxner as PAs, something like that. Those people, what we're proposing, and hopefully you will understand this, is that the chairman of the individual department, whether it's internal medicine, orthopedics, general surgery, whatever, is the supervising physician. And in his absence, it's the on-call for that service. So that way there's always somebody that can be available. We don't have to call the chairman in the middle of the night. And the chairman defines, because right now privileges are only granted through the supervising physician's credentialing that they're maintaining, so that the supervising physician as the chairman would have one for all of the PAs, or if he wants to have some special ones for some PAs that do more, that's fine. But it simplifies the work of the documentation and the things that need to be done to make sure that you're practicing in a proper supervisory relationship. So again, I know we don't always use term supervisor, we'll come up with another term, but nonetheless, I think the key there is to still recognize that there's dyads that need to be addressed and there's large groups that need to be addressed, and we have to make them so that they work for everybody.
So in regards to the billing, is there a way to motion that we would like something said that the rules for PAs are going to follow the federal guidelines for billing?
We can certainly look to that, or still be optional. That, I mean, it's not the federal guidelines, and we'll do some more research, and I promise we'll do that. But it's my understanding that that's not mandatory; it's optional, and so some people still work on a flat salary, and the doctor's or the doctor's office NPI number is doing the billing for them, and so. I don't want to disrupt those kind of practices because they still exist in rural Louisiana.
That makes sense.
It does, but I think and there could potentially be overlap in some salary structures if people are a production-based model, but the billing should not affect that. In fact, it harms the PA if they can't transparently claim the work that they're doing, if that makes sense. So again, I guess it's the recommendation of this committee, but LAPA's position on this was we wanted to see this eliminated altogether.
Okay, well, and again, do we risk disrupting the classic dyad to do this? Is that what you're comfortable doing?
Does the rule prevent, so regardless of whether or not there's a rule about billing, does it prevent what people can and can't do since it's a rule and not a law?
Well, I think you wanted to eliminate ambiguity. And I think it's important to eliminate ambiguity by saying if you're in an environment like the classic dyad where you're a salaried employee and the billing is all going through the NPI number of the doctor, that could continue. And if you are working in a production-based environment where the work you need to be done is done, they can collect that data on you and do the billing for you and determine your salary based that way. I think we're trying to make it flexible enough for all types of PA practice. And we know that this is an ever evolving situation. We're trying to make it available to everybody and whatever they need without necessarily saying we're going to kill one system.
I'm not really sure what kind of motion or what we would need to do, or if this is just something that can be added along into. I'm not sure what we need to do to move on, because I
Well,
don't.
again, I personally, you tell us what you want, okay, and we'll put it in. The board may change it, that's fine. But I think what we're trying to do is to accommodate all types of PA practice. I don't think we can force one people to change to accommodate another. And I don't think we should force the one system that's been in place to accommodate the new changes in the way PAs practice. I think we have a continuum that needs to be fairly and equitably addressed. And that's all I want you all to say we can do. But if you want to do it another way, say eliminate it altogether, we'll take that under advisement. The board will say, we don't like that, or change it to something else, and we'll do what we can do. But I like to see how you all think about recognizing the spectrum of how PAs practice in this state right now.
So I guess I'll speak on behalf of LAPA in this scenario as written. This has been restrictive to PA's practices, and we're looking for a solution to that. I think that you've brought up something that's potentially a potential unintended consequence, which is important to consider, which is more of not just the logistics of billing and reimbursement, but how that could potentially impact an employment structure for PAs. And I think the other thing to consider is not just the administrative level of the healthcare organization who's doing the billing, but the insurer side of this and how they would interpret, a change in MPI numbers and what we're going to accept and what we're not going to accept. So that's kind of a third arm to this. Which is not helpful. I'm just throwing that out there as well.
Well, and again, I'm trying to address those unintended consequences. We know that the original scenario works. I think if we make it clear that you may use, in other words, it's optional to use that number. For example, one PA may work in a classic dyad arrangement and doesn't want to change that. His employer doesn't want to change it. But then on weekends may go and work one weekend a month at a local emergency room where they would do a different set of. So I think we need to leave it optional, recognizing how the PAs practice today.
So Dr. Claude, I'd ask you this, but how does that differ from a physician who's doing the same thing, which is, moonlighting somewhere, who just bills under their own MPI number? It's clean, it's transparent, they could be paid via salary, they could be paid on production. It's the equivalent. Are there differences in the rules?
Okay, well, with physicians, the billing and collection is done by the physician. Are you all going to be in the billing and collection business? Did I misunderstand something? I'm
unaware of physicians that do their own billing and collections. I mean, that's typically the organization that they work for. But so even physicians.
No, Miss, with all due respect, Miss Sarah, you're leaving out the classic dyads and the way people practice in rural Louisiana. The classic dyad, the doctor does the billing and collecting for that practice and pays the PA a salary. Now, again, I don't want to disrupt that kind of thing, but if you're comfortable disrupting it, that's fine. If the board approves it, then we'll say that that's what LAPA asked for and we did what they asked for. But I think we need to be cognizant of PA practice is now a spectrum from a dyad to large group multi-specialty areas. And I just want to be able to address that for everybody. But if the committee says, no, don't do it, that's fine with me. It's less writing and drafting for Ms. Pat and I.
This is Crystal. I don't know the right answer here. And I don't know what to propose to move past this. I mean, I think I understand we need to address it in some way, but I'm not sure if we could table this and come back to it, or I'm not sure what to do at this moment.
Why don't you, if it's possible, would you let us draft this thing in such a way that it protects the spectrum of practice? And then when you revisit it, you can say, this is too ambiguous, you need to clear it up. I mean, if you don't want to protect the spectrum of practice, that's fine. Just say you don't want it, period, and that's fine with me too. But I thought we want to be recognizing the fact that PAs are an evolving area right now, and we want to make sure we don't make people think that we're changing the way they have to practice.
I think from LAPA's perspective, if something is drafted and we could vet it through a couple of different practice models, stakeholders, to see if they saw any issues or problems with it before it gets presented to the board, and maybe even like Blue Cross Blue Shield of Louisiana and Department of Health for Medicaid, just, you know, and then we have comprehensive stakeholder input that we're not going to cause unintended consequences and headaches down the road.
All right. Well, if you want, we can have another meeting in January and get those people as the stakeholders to come and talk about this issue if you want. I mean, I want to make it work for everybody. That's all I want to do. I don't want to make people feel like we're driving them, the way they practice and get paid is changing, and we don't want to do that to them. Are y'all comfortable having a meeting in January to address this with the stakeholders?
I don't know.
That require a meeting, or is there not an electronic review just to solicit feedback? Does that require an official meeting, public body?
Well, again, I think it's best that the committee does it so that nobody accuses us of operating in a vacuum or behind the curtain. I think you have detractors out there who you want to avoid a confrontation with. But, you know, we'll give it to the committee, and if the committee wants to dispose of it and let y'all do it that way, that's fine. But I advise that you want to do this in public with opportunities for public comment and everything else. But, you know, it's up to the committee. They can do it any way they want. I would give you, I think you don't want to get yourself at odds with people because you did something in the dark.
I think that's a great suggestion. If you could put some things together and then we can kind of revisit that in January. I think I would agree. We're not going to decide on anything tonight to jeopardize some of the independent practices that are across there. And I think we're going to need some options if you could help us.
We will do that for you.
All right. Thank you.
Great.
Before you leave tonight, though, I would very much like you all to pick a day, maybe in the second week of January, toward the end of the second week of January, to do this meeting so that we can get that document ready for you. You can see these things and you can say, and the stakeholders can come in and be invited and they can comment on it. Because that's technically public comment to the advisory committee. And that way, anybody who looks at this tape later on can say, oh, I didn't know they were doing that. Well, we did public comment and everybody was there and we did it. So it'll be noticed like every other public meeting we do. And anybody who misses it, it's not the fault of the advisory committee or the board. It's the fault that they didn't pay attention to what they needed to be paying attention to. So we'll do that for you. And if there's anything else you want to address, Ms. Wilton's got a hand raised.
Right. I just wanted to clarify the second week of January being 3 weeks from now. Are you talking about language just for this billing issue? You're not talking about the comprehensive rules?
No, just the language of this billing issue.
Cool, we can do that.
Yeah. All right. Anything else you want to address in that regard? All right, let me scroll down here.
The next thing is the health letters. These were emailed to me. I'm sure y'all had a chance to look at them. They were emailed to me from outside entities, just kind of in support of what we're doing. I don't know if anyone looked at those. I don't know that I can really answer questions about them because I did not come up with them. They were sent to me. But I don't think there's anything else we need to discuss regarding those letters. Is there anything else from you, Dr. Collada, about that?
No, I think we're designing those rules for supervision, as we alluded to earlier, to accommodate the classic dyad and the large group practices, so that you might have, instead of one supervising physician and one PA, you might have one director or one chair of the Department of Surgery at a large hospital where they employ 15 PAs, and he's the supervising physician for all 15 PAs, and they have their own practice guidelines and those kind of things that might be different from the same hospital's internal medicine department. But that way, we simplify the paperwork for you all. We simplify the requirements for documentation for you all, and it's just going to make it so much easier and address, I think, what the board wants, what you want, and make it clear that it's going to be easier for you all, and automatically designed that the locum tenens or in the backup of the absence of the chairman of the department would be the on-call physician for that department at that time. So I think we have a method of addressing what SCP Health is asking to do.
Okay, I think the next thing is this delegate IV therapy.
Yep. Now, admixture is going to be something that is going to be regulated in two ways. One, we're going to have to say that, these kind of admixture stuff have to be done in compliance with the standards that are out there, federal standards that are required with, just devices that may have hoods and things like that. That's just for compounding, but for admixtures. But other than that, if you want to have this happen, we'll have to have set up the system, and there'll have to be guidelines. There'll have to be, the privileges are going to have to be granted in ways that we address the spectrum of practice, but you tell us what you want to do, and we'll try and get it done for you.
Do we know where? I'm just confused. What is this? Do we know where this came from, or
came from a law clerk who works for a law firm that has a company that wants to do IV admixtures? Okay, and the simple question is, do you want them to do it? We would normally say in the present rule guideline, this would have to be something that would be done with, the kind of equipment that's required by USP, United States Pharmacopoeia, and their rules for admixtures, and also in alliance with whatever the guidelines of practice that the supervising physician has with that PA under the current rule. And we want to make sure that we can address that, and I think we can as we address the spectrum. But it's, right now you would have to have a delegation, it would have to have proper equipment, and it would have to be part of the guidelines. It's the way I read our current rules, and maybe Ms. Wilton reads them a little differently than I do, but I think this is something that can be done currently, but it has to be adherent to the things that are required for a doctor to do it, for example.
Do we need a motion about this?
Well, you tell me what you want to do. Are you comfortable with my interpretation of their request and the fact that as we draft the new rules, we make it work on the rest of the spectrum? Or do you want to leave it? Do you want to say no for now and let's see what happens? You tell me what you want to do.
my understanding is that if it's something that a physician assistant has been trained in and their supervising physician does it and it's within their clinical practice guidelines and then the scope, I mean, I agree with your understanding. I don't know that we would necessarily, I think I'm okay moving forward with what you just said.
Okay, good. We'll make sure that that happens for you. But we wanted you to know that because we're going to draft, Ms. Wilton and I are going to draft an answer to these people for the board to review in January, and we'll get that out after the board approves it. So then we have some issues that are going on, and these are telling you what we've done, what we're looking at. And so again, I think that the most important thing that I'm talking about is the locum tenens is going to be expanded, okay, rather than eliminated, okay? The locum tenens would be the person that in that large group, when the chair is not available, like on Saturday afternoons, the on-call physician for that specialty in that section of the large group, multi-specialty group, would be able to say that's who's the locum tenens that you can get your advice from and consultation with. So again, I want to make sure that that's understandable to you all and comfortable with where we go with these rules.
Are we needing to vote on these tonight in that?
No, I just want those are there for you to look at, for me to clarify and answer any questions, because this is where we're going to be taking the bulk of the rule changes from in the way we've tried to show you. I've tried to demonstrate to you tonight, and these are the issues we've addressed so far. And again, this is, we would add to it the discussion today about where we're going with the issues relative to billing and coding and that kind of thing.
Do we need to vote on these tonight in that saying we
Unless you
approve?
think there's something, unless you see something that's very egregious or uncomfortable for anybody, we'll work from that, and then you'll still have an opportunity to address it when we present you the final set of rules. But, save me some trouble and Ms. Pat some trouble. If you got any real egregious, issues that we're trying to address here, tell us about it now, because we're going to be using this document to help us get it going.
Do any of the other advisory members have any questions or comments about the rules or the document that they've put?
All right, let me quickly check to make sure there's been no public comment. Give me a moment.
Dr. Craven, were you going to say something?
We
No,
have
I was
no
gonna
public
say-
comment at this time.
No, I was just going to say no. Sorry.
So you have no public comment, and let's go back to the agenda. And let's make sure we don't miss anything. These are the current rules. Everybody knows what they say. And the next meeting would be January 14th, if that's okay with everybody. And we could do the issue relative to the concern about the billing, and we'll draft the plan to show you what it looks like. And you can bring the stakeholders that you want. Ms. Sarah, if it would be very helpful if you would give us the email addresses of the stakeholders you wish to invite, so that as we plan for that meeting, we can get those invitations out in enough time for people to be able to appear and discuss.
She maybe jumped off, but
Okay.
we can send her a message about that.
All right. Are you all comfortable with January 14th?
Nope.
No?
No, I cannot do that, that particular day. Sorry.
What about the 13th on a Friday evening, afternoon?
That particular weekend, I'm not available.
All right. That's one of the crew. Do we think we could get the other four?
Dr. Nikolic isn't on, so I don't know that I can speak for her, but
Well,
Look,
would
if
you
it's-
like to?
If
Wednesday the-
if it's only one issue, I can do Saturday. I don't think Friday's probably really inappropriate unless we're just trying not to get a turnout. The only other option would be, is there a weeknight such as this that we could kind of pencil in that people could attend if we're just addressing this one issue?
How about Thursday, the 12th?
I'm willing to make it happen.
I can make that work.
Let's do it.
fine with me.
Me too.
All right, then we'll go ahead and make that change to, so that it's gonna be, Miss Olivia and Ms. Jacinta, make sure that change is gonna recommend the meeting minutes, say January the 12th.
Wait,
And do you
Dr.
want-
Van, it depends on what time, because we have a 5 o'clock clinical lab advisory committee meeting on the 12th.
Okay, we got a conflict. Okay. Do you want to do it earlier in the afternoon for this one item? We could do it at maybe 3 o'clock, or do you want to do it later, another day?
I'd like to pick another day.
Another
All right.
day.
All right, so I'm trying to make it easy for Miss Pat. How about the Monday, the 16th?
That works for me.
But Cynthia, let's look at our schedule, make sure we got nothing going on.
That's Martin Luther King Day. I'm not sure if that matters or not, but will you be in office that day?
Well, the good news is none of us have to be in the office. So, I mean, Pat and I can do what we need to do and
Let's
But,
book the day. Let's do it. It's gonna
All
be
right.
great.
all
Yeah,
right,
we can do
so,
the 16th.
all right, so can we do it then? If it's, since it's a holiday, can we do it like 1 PM or 2 PM or 3 PM?
I'm still in clinic that day. I'm sorry.
Yeah, I prefer
so-
to do in the afternoon,
okay.
in the evening.
That's fine. I mean, that's why I was trying to figure, if everybody's taking off, I just want to make, so is 5 o'clock good enough?
Perfect.
All right, 5 o'clock then on the 16th. Everybody else is working. It's, like I said, most of us work on those days. It's a state holiday for our employees, but we'll make the meeting happen for you all. All right, is there anything out of business that you want to take up or address?
I think we need a motion to adjourn.
Just, okay, that would be fine with me.
Second. Thank you all. Have a great Christmas.
Everybody have a Merry Christmas and a Happy New Year, and please be careful out there this weekend. Don't get hurt in the ice or the snow or the sleet.